Welcome, everyone. This is a talk, a presentation to all of you who are considering bariatric, or as we like to refer to our specialty, metabolic surgery orientation. Our practice is in Hillcrest, here in San Diego. And some of you have already been to our clinic. Some of you will be coming in the future. I'm going to talk for about maybe 30 to 45 minutes and to try to give you an overview of our philosophy regarding bariatric surgery and what we feel are the important and salient points that you should know as you begin this endeavor to have this kind of transformative surgery. And it's important that you are well equipped with information and knowledge to take the tool that we're going to give to you and use it in a way that will enhance your quality of life and as well as your health and so I would really encourage you all to take notes if you can and make note of your questions as I talk. So in our practice here at Hillcrest with Scripps Clinic, there are two surgeons, Dr. Leanne Lim and myself, Dr. William Fuller. And some of you may have met Dr. Lim or myself already. Now, to start off with, I just would like to review essentially what obesity is sort of defined as. And it is recognized by the National Institutes of Health as a disease, a chronic and progressive disease, which originates essentially from the accumulation of too much fatty tissue in the human body. And from that, several diseases can result. But we do know that there are many risk factors that can contribute to obesity. And I'm going to talk about those here in the next slide. So when we look at this particular problem, we know that it's not just one specific aspect of someone's life that leads to this condition. We know that there's a strong genetic component, the obvious nutritional aspects that go along with it, hormonal and metabolic issues that patients are confronted with. Obviously, the exercise and activity levels are playing an important role, and the sedentary lifestyle that many of us lead can lead to this particular problem. And then there's just another sort of offshoot of these sort of primary issues, which includes, sleep and stress, and then finances and lifestyle and all other kinds of things. So we're going to detail some of these things shortly and in more depth. Stand by for just a second. Okay, so we know that obesity can put you at risk for many diseases. We know that diabetes, high blood pressure, heart and lung problems, high cholesterol, stroke, joint problems, sleep apnea, many types of cancer are associated with obesity. And so it is a systemic disorder that affects multiple organ systems, as you see detailed in this slide. We know that the prevalence of obesity in our country is high. We know that weight loss programs that patients have tried are usually not sufficient over the long term by themselves, and that inevitably many patients gain back their weight and then possibly even more weight after not being successful in a weight loss program. Surgery, we know, provides the best long-term success, especially for patients with class 2 and 3 obesity. So, who does qualify for bariatric surgery? Well, based on the American Society for Metabolic and Bariatric Surgery criteria, currently, patients with obesity class 1, BMI greater than 30, with specific obesity-related medical problems do qualify for surgery. Similarly, patients with obesity class 2, BMI 35 or greater, and above qualify for surgery. And what is BMI? Well, BMI is an objective measurement of obesity. It is the weight in kilograms divided by the height in meters squared. And this body mass index, as we call it, is a way that we can sort of categorize severity of obesity. It is by no means completely accurate to detail what someone's obesity severity is, but it is a useful substitute that's very handy for us to get an idea of the severity of the weight problem. So what we know is that patients with class 1, 2, and 3 obesity can be candidates for surgery. So that brings us to Scripps Mercy Hospital here in Hillcrest, where we are a center of excellence, an accredited center of excellence for metabolic and bariatric surgery. And we have a long-standing history of excellence in care of our patients who are seeking weight loss through surgery. We do undergo a voluntary, independent, and vigorous evaluation, which is in accordance with nationally recognized bariatric surgical standards, meaning that we are dedicated to maintaining strict standards and improving the quality of care for our patients. So that's what that means. Those of you who are going to be having surgery at Scripps Mercy Hospital should recognize that you would be having surgery at one of the longer hospitals performing bariatric surgery. So just so we know. We've performed well over 20,000 bariatric surgeries at Scripps. We adhere to the NIH program design, which means it's a multi-specialty program with medicine and anesthesia, psychosocial support, nutritional support, and then, of course, monthly support groups that meet. Okay, that's just a little bit of background about our practice. Let's talk a little bit about the actual surgeries that we perform to help patients lose weight. Currently, there are two predominant bariatric surgeries for weight loss. There's the Roux-en-Y gastric bypass and the sleeve gastrectomy. And these procedures are done laparoscopically. Okay. Let's go into what those are. Okay, so we have on the left side of this slide, we have laparoscopic surgery with the ports that we use to do the procedure, typically 5 of these small incisions. And this is compared to open incision surgery, where there's a midline, long, larger incision, which can have more morbidity for the patient. We have largely supplanted the open surgery almost completely. And now, again, almost exclusively doing laparoscopic surgery for patients seeking weight loss. Let's talk about the sleeve gastrectomy. Again, done laparoscopically. And what we do in this surgery is we staple the stomach in a longitudinal way. And the stapler we use, it cuts and leaves staples so that our patients are left with a very narrow, lower volume stomach. And the excess stomach is removed entirely from the abdomen. And this is typically somewhere around 70 to 80% of the volume of the stomach. And this is completely removed, thereby leaving our patients with a narrow conduit for the transmission of food from the esophagus and then into the small intestines. And this is a very safe surgery, and it's a very effective surgery. As compared to the Roux-en-Y gastric bypass, which is done, again, laparoscopically as well. And in this particular procedure, we staple the stomach in a fashion that makes a 1 ounce gastric pouch that you can see depicted here. And this 1 ounce gastric pouch is attached to a limb of intestines, which is actually known as the Roux limb. And this, after the construction is completed, then food is carried from the esophagus into the gastric pouch, and then out this special small intestinal Roux limb, and then into the colon in the usual way. Now, in this particular surgery, the old stomach, or the remnant stomach as we call it, remains inside the abdomen so that all of its acids and other digestive juices, along with bile juices and pancreas juices entering the small intestines and the duodenum, are then carried downstream to then interact with the food that has been consumed and had made its way through the gastric pouch. And all that mixes here downstream, where we've rerouted the intestines and connected them in a way that those digestive juices can aid in digestion. And thus, all of the food and the digestion then moves its way through the small intestines. And that's laparoscopic gastric bypass. Again, both surgeries involve a dramatic reduction in the volume of the stomach. And that's the predominant way through which these surgeries help patients to lose weight and to keep it off. That is, there is profound restriction in the portion sizes and meal sizes that a patient can take in. And that's the predominant way through which these surgeries work. Now, there's some other mechanisms that play in both surgeries that help with weight loss, and some of those have to deal with gastrointestinal hormone changes, and this is more profound with gastric bypass, but there's simply that does also happen with the sleeve gastrectomy as well. Now, weight loss surgery in the year 2023, as we look into 2024, weight loss surgery is a very safe surgery. They are a safe set of surgeries. Now, with both this gastric bypass and the sleeve gastrectomy, there can be certain complications, and these are predominantly infection or bleeding or blood clots in the legs, known as deep venous thromboses, that when they move to the lungs, they're called pulmonary emboli, and that can be a dangerous condition. Leaks can happen in both surgeries, Narrowing or strictures of the sleeve stomach or the gastric pouch can occur in both surgeries. Ulcers can occur, most likely in gastric bypass, but certainly not unheard of in the sleeve. Dumping syndrome is exclusively or almost exclusively a gastric bypass phenomenon. Um, and it's not so much a complication as it is more like a side effect that occurs when patients consume more or less processed type sugars in high concentration. And this syndrome is a constellation of symptoms, which includes uh, feeling jittery, heart racing, sweaty, nausea, and then also potentially diarrhea and bloating. So that's the dumping syndrome. The risk of dying after a weight loss surgery is 0.3%. It is very low possibility of this, but again, it's not 0%. Keep in mind that many patients that we operate on do indeed have a variety of serious medical conditions that diminishes one's ability to respond if a complication does happen. So uh, even though, despite this fact, the risk of dying after one of these surgeries is very low. Now, specific to gastric bypass surgery is a complication called internal hernia. And this is a special hernia that occurs because of the way the surgery is done inside the abdomen and the way rerouting of the small intestines has to occur. There can rarely be sort of spaces that are created that can entrap small intestines. Now, this risk is low. I'd say it's 1% or less, and easily less than 1%, but it's not 0%. And if it occurs, it might mean another surgery. The sleeve gastrectomy, what you should know about that is specific to this procedure, is the relatively higher possibility of developing acid reflux, or if you already have acid reflux, of this condition worsening. And this can be 10, 20% of patients. So it's not an insignificant number. And it's something to be fully aware of. Now, the vast majority of patients who may develop worsening acid reflux typically are easily treated with medication, or some just need to make additional dietary behavioral modification. And in rarer instances, but still not 0%, conversion to gastric bypass surgery to help them. We at Scripps Mercy Hospital, as a community of surgeons over the several decades now, we've been fortunate in having low complication rates. Our experience in doing bariatric surgery at this hospital is beyond that of any other hospital in this county. We do quite a number of surgeries per year, but we do a safe number of surgeries, and really focus on good outcomes. So in 2022, we did 1,041 surgeries at Scripps Mercy Hospital with an overall complication rate that was low. This includes readmissions of 4.1%, 0% leaks, bleeding around 0.3%. So, which procedure is right for you? Well, this decision is best made in concert with consultation with your bariatric surgeon. You are likely wondering what decisions or what kind of factors would make a difference in which surgery you want to consider. And what I would tell you is this: there are some things that you should be aware of that go through our minds as bariatric surgeons when we're counseling you on which procedure we think is best. So, for instance, many patients with diabetes are going to do better with laparoscopic gastric bypass. Many patients who have existing GERD, gastroesophageal reflux disease, are going to do better with laparoscopic gastric bypass. However, there are some patients who, for instance, may have had significant lower abdominal surgery, and by that I mean lower intestinal surgery, like small intestinal surgery. They would be better suited for sleeve gastrectomy. Uh, and these are just a few of the considerations that we as surgeons would have in recommending a surgery. We do also strongly consider for patients who have BMIs of 50 or greater that they need more durable and more weight loss, in which case gastric bypass would be a better surgery in that instance. So this is not an exhaustive list of all the different sort of variables that we consider, but this gives you an idea about the thinking that we put in to help you make a good decision. So we've already talked about body mass index. You'll hear us sort of tossing around different scales or measurements of weight loss after surgery. So the percent of total weight loss, you can see the arithmetic there, or more commonly in the surgical realm, the percent of excess weight loss, which is your initial weight minus your postoperative weight divided by your initial weight minus your ideal body weight. Okay, so that you'll hear us mention somewhat commonly. And so, for instance, patients who choose the sleeve gastrectomy typically lose between 60 and 65% of their excess body weight. Similarly, gastric bypass patients typically lose between 70 and 75% of their excess body weight. But it's not about just weight loss. We know that there are tremendous other benefits that our patients are going to experience as a result of weight loss surgery. And we've listed some here. This includes cancer reduction, taking fewer medications for those women of reproductive age, improved fertility, improved quality of life overall, and probably most importantly, increased longevity. Life expectancy of bariatric surgical patients compared to their cohort of patients who do not get weight loss surgery, those who get weight loss surgery live longer. And that's been documented in several studies. So what should you do now? Well, it's good that you're at this webinar because this is a good start. But we also think there's more that you can do to ready yourself for bariatric surgery. And you can see from this slide, this includes having a positive mindset. And I think it's helpful to go to support group that we have now for post-op patients, even as a preoperative patient, to learn what it's like or to get an idea of what some of the challenges our patients may experience after surgery. And I think that helps put you in a more positive mindset. Learning the facets of healthy eating. And some of this includes eating protein first, eating slowly and in smaller amounts, chewing well, and practice sipping your fluids rather than drinking them at a faster rate. Also includes starting an exercise regimen. And, if you can do 30 minutes, 5 days a week of some reasonable exercise, ideally that gets the heart rate up, this is a good start. And it will put you in good practice for after surgery. And it's a good idea to start a multivitamin daily and to get accustomed to drinking protein drinks. In fact, it's a good idea to choose your protein drink now so that you learn what kind of tastes you like and don't like. You don't want to find out after surgery, not having tried your protein drink, that you think it's awful, in which case it makes you nauseous. And that's a bad time to find that out. So start your multivitamin in your protein drink now. And that's similarly with the multivitamin also. Sometimes the multivitamin can cause nausea in patients. So pick a formulation now that's going to be agreeable to you. All right, so this slide is designed to give you a perspective, a flow chart on how things move from this standpoint onward. So in the continuum that you see listed here, there's the pre-surgery preparation. And this includes being at this webinar, having a surgeon consultation, eventually internal medicine evaluation, psychological evaluation, the healthy habits that I just mentioned in the previous slide. And this is a good way to get yourself moving ahead. Now, after you've gotten approval and things, and you get your surgery date, you get your surgery. And most of our patients stay overnight in the hospital. Some may need an extra day, but the vast majority of our patients are discharged usually within 2 days of having had surgery. And then after you've had surgery, there's a progression in your diet where you move from liquids to parade foods to more semi-solid foods over several weeks' time. And we'll go through that progression with you. You'll learn that. Additionally, you'll have frequent follow-up with your surgeon. And this includes follow-up that can be 1 or 2 weeks after surgery, then 6 weeks after surgery, 3 months, and then typically 6 months, and then annually for some patients. For some others, it may just end at 6 months, depending on your insurance. Then we also will make sure that you're doing your bariatric supplements, the multivitamin and calcium citrate with vitamin D. We'll remind you of the importance of an exercise regimen and the importance of support group in your postoperative life. Speaking of life, you will then go off and live a longer life, odds are. This will include regular follow-up with your main doctor, visiting with a nutritionist and possibly a psychologist if you need to. We also would recommend that you have annual blood work to assess your nutritional status. And in addition to that, all the healthy habits that we've talked about already, which we will always remind you is very important to maintain the weight loss that you've achieved 1 year after surgery. Okay, so surgeons across the country have a variety of different opinions regarding the items that you see on this slide. Suffice to say that what we do in our practice at Hillcrest, it could be different than what someone else does across town. But here's what we would suggest. For the vast majority of women of reproductive age, you should avoid pregnancy during your first year after having weight loss surgery. Similarly, caffeine, alcohol, red meat, juices, and gum should typically be avoided in the first year. And for some patients, they may need to avoid those kinds of substances for life. And then there's the for life category that you see, which includes not using non-steroidal anti-inflammatory drugs known as NSAIDs. And these are medications such as ibuprofen, Aleve, Motrin, Naproxen. These kind of medications, many of which are available over the counter, and we use for headaches or pain, joint pain, musculoskeletal pain. These kinds of medications should be avoided if you're a bariatric surgical patient due to the effect of these medications on the lining of the stomach itself. Similarly, though not through the same mechanism, aspirin should be avoided if at all possible. Smoking cigarettes or vaping or smoking marijuana, hookah, any kind of smoking should be avoided for life after any kind of bariatric surgery. And the drinking of carbonated beverages, we strongly encourage you to avoid for the rest of your life. You have to remember, as you see in this next slide, we strongly believe that bariatric surgery is the most potent tool that our patients have to help them achieve a healthier lifestyle. But as you see from this slide, it is a tool that requires your lifelong commitment, along with the adoption of healthy lifestyle habits. And if you do those two things, we really, really have seen great success among our patients. Okay, that's everything that I kind of wanted to say. You want to take note of the website scripps.org, as well as our phone number, 619-298-9931. Those are the avenues to contact and reach out to us so we can get you in for a consultation and get you on your way. Now, we're going to conduct a Q&A session here shortly. Again, the reminders are, we don't really want you to ask your personal medical questions related to your specific medical problems in this particular venue. We want you to ask general questions, again, not about your specific medical conditions. Save those for the consultation with your surgeon. Okay, so your medical questions about your specific medical problems should wait for consultation. Okay. All right. So when we go through this, I want to remind everyone also that we are participating in the B-Stop Bariatric Surgery Targeting Opioid Prescription program, where we, through the use of very potent non-narcotic medications, we are able to treat our patients' pain successfully without using opioids, and thereby contributing to the opioid pandemic. And we have dramatically curtailed the use of those types of medications using our ERAS protocols and what you can see there, the non-narcotic medication. Just a couple of reminders about the need to take bariatric formulated multivitamins with minerals that we're going to teach you about, calcium with vitamin D, getting in proper protein, attending our support group, and having regular follow-up with us as your physicians and your nurses and your dietitians, and this is what's important. So that concludes my presentation.